Welcome to Voices for a Healthy Legacy, where we discuss health and wellness with relatable medical professionals. I am your host, Dr. Andrea, a board-certified family medicine physician. Today's guest is Dr. Mia, who is a board-certified OBGYN and total wellness expert. Welcome to the show.
Thank you for having me, Dr. Andrea.
You are so welcome. So just start out by just telling us a little bit about yourself.
Well, I'm from Birmingham, Alabama, and I have owned my own practice for 13 years, MiBella Wellness Center, right here in Greystone in Birmingham, Alabama. And I am a board-certified gynecologist. I help men and women suffering with weight gain, fatigue, and sexual dissatisfaction improve their quality of life through my cutting-edge total wellness solutions at MiBella. So, yeah, that's a little bit about me.
Okay. So tell us what inspired you to go into medicine and to also become an OBGYN.
Very good question. So basically my mom was a nurse. So she retired after about 40 years of being a nurse. But when I was younger, she did home health care. And when she did home health care, sometimes she would be doing extra stuff for her patients, taking them something back, and we would go with her. And I just saw how well she connected with her patients and how much they appreciated her. And so I told her in about 7th grade, no, I was probably younger than that I wanted to be a nurse. And so she said, no, Mia, you should be a doctor because you're good at math and you're good at science and you're really smart. So you should plan to be a doctor. And so from that day forward, I was just like, okay, I'm going to be a doctor.
Right.
And then I majored in, biology. I knew I was going to be a doctor probably from the time I was in 7th grade. And I thought I was going to be a pediatrician and I was going to teach young children to grow up and be healthy adults. And
really?
You know me quite well. So as you know, I probably wouldn't have made a good pediatrician. So I did and I knew for sure when I was in med school, I knew for sure that I wasn't going to be an OBGYN and I knew I wasn't going to be a psychiatrist. I was like, I know that for sure.
Really?
So between going to med school and finishing undergrad, I did my master's in health education and promotion. And so that's what got me into the preventive health side. So when I did my rotation, I actually did my OBGYN rotation at an off hospital because I knew I didn't want to do that. So the first day I just fell in love. I like the women's health. I like the variety of the day. I like being able to go deliver babies and then operate and then be in the office and teach women and be able to help somebody with a problem and give them a real solution that I could somewhat control. You know what I mean? Not just their behavior, but I could actually fix abnormal bleeding. So I just absolutely loved it. And I was so mad because I did not want the lifestyle of an OBGYN. I did not want to wake up in the middle of the night and deliver babies. But I couldn't do anything else because once I did it that first day, I fell in love with OBGYN.
That is so funny. So that first day when you're like, oh my gosh, I love this. Like,
I was so mad.
Shock?
Yes, I was in shock because I was like, wow. But then she let me deliver the baby or help deliver the baby on the first day. She let me do so much hands-on. I did my first, exam, my annual exam. But she was right there with me, talking me along. But I just love the variety. I love the excitement. I love surgery and I like somebody just having a problem and I could fix it. So, and I love women and I am a woman, you know what I mean? So I kind of fell in love with women's health. I know it's a great way for prevention. If you take care of the woman of the household, then the rest of the household will be healthy. Yes. So just all the things kind of came together as one. Good. And I always wanted to decrease the health disparity for Black people in America, Black and brown people in America. And so this is a perfect opportunity for me to do that with women. So.
Well, look, it's like you just saw saw your purpose just flash before your eyes. And then one day you were like.
But it was really it was over time. It was slow and unfolding. You know what I mean? Even before I knew I wanted my own practice. So Joseph always says, Mia really built this practice back in 1999 when we were in Birmingham at the Bessemer New Year's Eve party. And that was the night we decided we were going to be together forever, but we weren't going to get married no time soon. And I was telling him, I wanted to have my own practice. I wanted to be multidisciplinary and this, and this. But even at that time, I didn't know that I wanted to be an OBGYN.
Wow. I never knew that. And I feel like I know a lot about you, but I never knew that part. Okay. So. All right. Women have different experiences in their 20s, 40s, 50s, and so on. And so people are sometimes confused as to exactly when they should start seeing a gynecologist. So what are your recommendations for when someone should start and what should they expect during that first visit?
So good question. So I recommend between the ages of 13 and 15, earlier if young ladies are having a hard time with their cycle. So I always say that no girl should be missing school because she's having cramps and heavy bleeding and nausea and vomiting. She should not miss school because of her cycle. If she does, it's time to go see a doctor so that we can start coming up with some things to improve her quality of life. But if they're not having any problems between 13 and 15, and again, that's a good time to come in and talk about prevention, talk about normal screening, talk about sexual education, vaginal health, what a normal cycle is and what is not. And a lot of people don't know that it's not okay for their girls to skip cycles after they start for so long of a time, or if they're gaining weight, it's a great time to start getting them into that healthy lifestyle. So I say 13 to 15, and those are going to be the things just really getting used to in the little education. And then you continue. You definitely want to start having PAPs by the age of 21. I recommend if your daughter's in high school, they should definitely be seeing a gynecologist, having some good conversations, some good education for prevention and screening if necessary.
Right.
And then it just really goes all the way throughout. So then you're 21, you're more interested in probably birth control for some, some people want to have babies early, but birth control. And then you want to talk about preserving fertility. Now a big conversation with my ladies in their 20s is, possibly freezing eggs. Ladies are getting married later, they're into their careers, but you do have the opportunity while you're young to freeze your eggs so you're not stressed out about trying to get, married early or just settling because you want to have a baby. You'll still have that option even later in life. And then time for fertility. So now you're getting ready to start having babies. And, that's a good time too, because some people may need help. It may not happen when they want. And then just your overall prevention, making sure you're getting your pap smears. And then by your 40s, that's when your hormones are starting to change. If not before, you start getting your mammograms, then you start hitting the menopause, the real menopause. So, for every stage of life, it's something different for women and hormones and, what we need and what, why we need to go to the gynecologist. But we should be going to a gynecologist and a primary care doctor.
Right.
At the same time. Okay. Your gynecologist should be your gynecologist. Your primary care doctor should be your primary care doctor. So you have both to work with.
Right. And we do, as a primary care doctor, we work hand in hand.
Right.
And I feel like a lot of people don't realize that this is a relationship that you should have and value just like any other relationship that you have in life. Because, even though it's your body, we're here to help guide you.
That's right.
And when things change, we can tell you, well, that sounds normal or that's not normal. That's right. And we'll talk about this a little bit later, how some women feel like the older they get, as their bodies change, they have to suffer through certain things.
That's right. Right. We don't do that. Look, we live well and age well, okay? So we can have what? Right. Everlasting intimacy.
Right.
But really,
and I think so many women feel like they have to, quote unquote, settle. And, we know certain things are a part of getting more seasoned in life. Right. But there are ways to offset some of that as well. Right. So we're going to talk about that. Yes. We know that the recommendations can change as to when you should get pap smears at this time, starting at 21, like you said before. But will you talk about the purpose of pap smears? Why we get them is not torture, what your options are. Can you talk about that and educate our audience on that?
That's actually a great question, because sometimes I just poll my patients and I'm like, so do you know why you get a pap smear? And a lot of times they're like, no, because I'm supposed to get one. No, you actually get a pap smear to prevent cervical cancer. So it's one of the few screening tools that we have that can actually prevent cancer. So if you still have your cervix and you're at the age of 21, you should be having pap smears. They say every 1 to 3 years. I personally say see your gynecologist every year, because a pap smear is a small component of your annual. When we do your annual, we do a breast exam, we do your vital signs. Sometimes we check labs. We examine your abdomen. We examine the outside of the vagina, the inside. We look at the cervix. We feel the uterus. We feel the ovaries. We feel the tubes, So we're looking for pathology. So that's the annual. But a component of the annual is the pap smear, where when I'm putting that speculum in, I actually have the cervix in my view, and I take a sample of the cervix and I send that off, because any woman who walks around, and man who walk around on earth, they are going to be exposed to human papillomavirus, HPV. It's not a sexually transmitted infection like chlamydia or gonorrhea. Actually, women who've never been sexually active can have HPV. Okay. So HPV can do nothing. It can cause genital warts. It can, which is benign, or it could lead to cervical cancer if it's affecting the cells on the cervix, and we don't know. So that's why we do the pap smears, because we know it's rampant in the population. Everybody's going to get exposed to HPV. So if you're exposed, a lot of times that does nothing, and sometimes that can start to change the cells on the cervix, which we call like dysplasia or abnormal pap smear. When that happens, we confirm that it's nothing to be concerned about, and then we monitor you closely and have more pap smears until your pap smear goes back to normal. If we can't make it go back to normal and it continues to progress, we do a minimally invasive procedure that sometimes can be done in the office or in an outpatient center, and we remove the abnormal cells. But because of the invention of the pap smear, that's why you never hardly hear of a woman having cervical cancer in America. If you have your regular pap smears, you should never get cervical cancer, So It's a great screening tool. It's only a component of the annual. So you should see your gynecologist every year up to the age of 65 for your annual exam. You get pap smears if you still have a cervix. So if you have a hysterectomy and they remove your uterus and you don't have a history of abnormal pap smears, you may not need to continue to get the pap smear, meaning the component of the annual exam and the pelvic exam where we're just taking the cells to confirm that you don't have cancer.
Right.
So preventable disease, we do the pap smears, but we also check breasts, make sure you're getting your other screenings like your mammograms, your colonoscopies. Women get fibroids in their 20s, 30s, 40s, so we manage those. Anything abnormal on the outside or inside. So a pap smear is a small component, depending on your history, every 1 to 3 to 5 years is what they say. What I do for my patients is I do an annual every year, but I do a pap smear at least every other year if you're low risk and you've never had an abnormal pap smear. But a lot of times I'm just like, we're doing the exam. Let's just go ahead and do the pap. And if it's normal, it's fine. If it's not, we know to watch you more closely.
Right.
So, so that's the pap smear. That's why it's important to get it, because it prevents cancer.
Talk about a few common women's health issues that you see in your practice besides hormones, because we're going to talk about that a little bit later.
So fibroids, very common. About 70 to 80% of women have a fibroid. We don't have to bother them if they don't bother us, but that's one of my most common problem visits is abnormal bleeding, whether it's related to fibroids or aging or change in hormones or PCOS. And then, managing early hormones like with insulin resistance, or polycystic ovarian syndrome. That's a very common, health issue, especially with the population becoming more and more obese. Mm-hmm. And that's when women have insulin resistance. They may not really have diabetes, meaning their hemoglobin A1C is normal or their glucose is normal, but they may have other signs of insulin resistance like thinning hair or acne and facial hair at a young age, thick hair around the nipples, thick hair on the belly, skipping cycles, not being able to lose weight, gaining weight easily, the darkness on the back of the neck. Those are all signs of polycystic ovarian syndrome, which tells us that you're at high risk for diabetes.
Right.
So we are managing those cycles. It increases the risk of having some infertility issues. So we work with PCOS a lot, and we work with endometriosis a lot.
Okay.
So about 10% of women have endometriosis, which is a, pretty significant and sometimes complicated, benign disease of the pelvis for women. And it's where the lining of the uterus grows outside of the uterus, and it can cause pain. It can cause abnormal bleeding, pain with intercourse, infertility, severe depression and anxiety. Mm-hmm. So it's a very common benign disorder that we manage. And now we have so many good things that we can do to manage that so much better. So those are some of the main diseases. And then, of course, changes in the vulva. So lesions or cysts on the vulva, not a lot of stuff vaginally except for vaginal health. So preventing infections like bacterial vaginosis, yeast infections, and then sexually transmitted infections, treating those and screening for those. So I would say those are some of the main, and then I focus on total wellness too. So I'm always making sure my patients are getting their other screening, managing their weight, because weight negatively affects so much in gynecology, abnormal bleeding, PCOS, infertility, worsening fibroids, pelvic pain. So all the things. So we cover quite a lot, and we work with our fellow primary care doctors so that we can, have our patients to be healthy and prevent disease.
Right. Mm-hmm. So you mentioned fibroids, and there are so many women who equate I have fibroids to I have to get a hysterectomy. And I know how you feel about that. So can you talk about, and I know that some people may end up having to have it, needing it, rightfully so, but talk about how you feel about fibroids and hysterectomy and things like that.
Okay. So back in the day, the only option when you had fibroids and abnormal bleeding was like a hysterectomy to stop it. But now in 2023, almost 24, in 2024, we have we have a lot of other options. So sometimes if they're small fibroids, we can simply give birth control pills or hormonal medications or medications that are specific to, which may have hormones, to treating fibroids, abnormal bleeding, and the size of fibroids. So we have just simply medications. We have non-hormonal medications. We have lifestyle changes. Mm-hmm. We have minimally invasive surgery where we can look inside of the uterus, even in the office, with the right, local anesthesia. And we also have going to the hospital where we can look inside, remove polyps and fibroids through the vagina. We have it where we can just remove fibroids. We have it where we can kill fibroids. We have we have so many treatment options. So, that's usually the progression that I go. I start with what's the easiest way to treat this that may work. And then we continue to progress. And I base it on my patient's understanding and how they want to have a quality of life and if it's truly affecting their quality of life. Hysterectomy is an option. And for some women, they need a hysterectomy. But the good news is that with technology, most women don't need a hysterectomy because they have fibroids. There are so many things we can do well before we go to a major surgery and remove your girl parts, your uterus and your cervix and your tubes, usually when you have a hysterectomy. But the thing is when you do have to have a hysterectomy because your fibroids are so large or you're having an abnormal bleeding and we tried everything else, maintaining the ovaries is very important.
Yes, I know you are so very
don't
big
just
on
let
that.
these people take your ovaries out because you're having a hysterectomy and you're like, I don't want to have another surgery, so just take my ovaries. Ovaries are so important because they protect the heart, they protect the bone, they help protect the breast, and they decrease the risk of dementia because the hormones in the ovaries are very important. So we don't want people just yanking out ovaries, even if you need a hysterectomy, just because you're doing surgery, because it increases the risk of death from heart disease by removing normal ovaries before the age of 60. We used to say 60. Now we say 50 to 60.
Okay, good. Thank you, Dr. Mia.
Yeah.
All right. So you've delivered hundreds, if not thousands, of babies, Dr. Mia.
Yeah.
So, you talked about, how you fell in love with not just GYN, but OB. But at some point, you kind of shifted or pivoted and you just started doing gynecology, and we'll talk about your other services. Mm-hmm. So tell me what family member kind of made you decide to kind of drop the OB part and why?
Marley, so my baby. I finished residency and started at Cooper Green and served the indigent population of Birmingham on purpose. And I worked there for 4 years, so I delivered babies right out of residency. And then once I finished delivering there and I realized that I don't work well for men and I wanted to start my own practice, and I went and got my MBA. When I was going to start my own practice, I wasn't going to include OB. One, because I just was over it, and I didn't love it, and I wasn't as passionate about it anymore. I didn't mind helping women to get pregnant, but the delivery process, me leaving my home and going away from my own daughter, who was about 2 at that time, you know what I mean? Right. I just didn't want to do that anymore. So when I lost my passion for it, I was like, well, God has another plan. Right. So we're going to drop the OB, and I started focusing on the weight management and the gynecology, and then all the other stuff just followed based on what my patients need.
Okay. Mm-hmm. All things dealing with women's health is your passion. Mm-hmm. And so will you talk about your weight journey and why you decided to make that a part of your mission with your practice to incorporate that and offer that to women as well?
Great question. So, when I was still working at Cooper Green, I had my baby. So I had Marley at 33. And when I had her at 33, it was the first time in my life that I was not on a diet. So I was so excited about it. So we ate everything. We had burgers and milkshakes and fries, and I would just
all the good stuff.
Yeah, all the good stuff. So as a result, I gained about 60 pounds when I had her. Mm-hmm. And I felt terrible. My knees were hurting, my back was hurting, I was irritable, and I could not get the weight off. So I was had been telling my patients, just eat healthy and exercise to lose the weight, because that was what I could do in my 20s.
Right.
So when I hit my 30s and gained that weight, that was not working. I was doing 2-a-days, but I still was eating a lot. So I couldn't lose the weight. And so that's what got me interested in learning how to lose the weight and then being able to teach my patients. Because I then felt guilty, because I'm like, I've been fussing at my patients all this time. Like, all you need to do is cut back from the table and exercise. But it's really not that easy after you get to be a certain age.
Right.
So that's when I found the Center for Medical Weight Loss, and I went and did some training with them so that I could learn how to teach my patients how to lose the weight the right way with a focus on behavior modification. And so while I was doing that, I learned how to lose the weight myself. And so I lost the weight, but I realized that it's a real science to weight management. It's not as simple as just cutting back from the table and losing the weight and being able to keep it off, especially as we age and our hormones change and we mature, you know.
So let's talk about hormones. So I know another part of your practice is helping women with changes in their hormones and different things like that. So can you educate us on what kind of hormonal changes you see often, and who's a good candidate for hormone replacement and like the different types of hormone replacement?
Okay. It's a loaded question.
Yeah. We need to know. We need to know.
So after I started MiBella in 2010 and I lost the weight, I was able to keep it off. So then I was able to keep it off, and then I hit about 37, 38. And that's when I started noticing that the weight was coming back on. It was harder for me to keep it off with the same habits. My libido went away. I was having night sweats. I was having more belly fat and joint pain. I was irritable and ugly acting. I didn't like myself, and other people didn't either. I couldn't focus and remember, so I felt like my adult ADD was really starting and getting worse and worse and worse. So that's when I was taking care of patients who were gynecology, and my patients had all been complaining of these things. But when I started experiencing, I was like, oh, they ain't talking about just a little tired. They're talking about severe fatigue.
Right.
Like, it's hard to get yourself out the bed. So I started doing some research, and I had already started like diving into hormone creams, because that's all I knew to do with the testosterone, because I realized that estrogen and progesterone, those are the common ones that we replace. That's when you are in real menopause, where your ovaries are not producing that. But initially you start producing a lot of testosterone, and that's when the symptoms I just described start to happen. You're not sleeping, your sex drive is low, it's harder to have orgasms, you're having night sweats, you're moody, you're gaining weight, you know, your joints hurt, you just all over the place, right? All the things. So that's when I started really diving into more of the testosterone cream, and I realized that testosterone does work. And then I met this old man at a conference, and he was like, do you do hormones for your patients? And I was like, yes, I used to bioidentical hormones. And I was all proud because I was using the creams and nobody else was really doing it. And I saw how much it helped my patients. So he was like, well, you're doing your patients a disservice. You need to find out about pellets. You need to research it, and you need to figure out how you're going to offer that to your patients, because you will change their lives.
Is this just
this random old white man who was a retired OBGYN that I was just talking to on the plane after a GYN conference. And so when he said that, I started researching, and I finally found a company, BioT. And I went to training. And when I went to training, they were like, well, hey, get your hormones checked before you come. So if your hormones are low, you can go ahead and get yours replaced, and you'll know how to explain it to your patients.
Right.
So I got mine checked, not even realizing really that all that stuff was going on, because it comes on so gradual. So I hadn't identified when I went to this training that I really needed the hormone pellet therapy. I just knew my patients were not getting the results I wanted them to get with what I was doing. So I wanted to try something different. So I went down there, had my blood drawn, and she was like, oh my God, your testosterone is like 10. So I was like, well, yeah. And she was like, well, let's go ahead and do your first pellet. So I did my pellet while I was training, learn how much testosterone helped with not only feeling better and aging better, but also protecting the heart, the bones, the breast, and the brain. And so I got my first hormone pellet. And mind you, again, I didn't really acknowledge that I felt the way I was feeling, but I noticed like after 2 or 3 weeks, like I woke up and my alarm clock went off, and I thought I was late because I hadn't slept through the night in so long.
Really?
But I hadn't even thought about it. I just was used to waking up in the middle of the night, going to the bathroom, or having night sweats, getting up, taking my clothes off, going back to sleep, waking up. But it had become a norm because it was so gradual.
Right.
Then I remember I used to try to act like I was sleeping. My husband came to bed because I did not want to have sex. I was not interested. I was tired. It wasn't that I didn't love him. that was just not my interest. And then I had to work real hard to have an orgasm. So then you're like, well, why am I doing this? So then I noticed I was, but so then I just started noticing things getting better. And like my son had gone away because he graduated from high school and he came back. He was like, you're so much nicer. You know what I mean?
Wow.
So I realized that I needed the pellet, just the testosterone. I didn't need estrogen at that point, but it really changed my whole life, my energy, what I could accomplish. It helped me with my goals. Like my practice started to flourish and thrive because I had energy to think and be creative. I was more social. I was out networking. I had the energy to do all the things. And it was all because I had my hormones balanced.
Wow.
Yep. And then that kind of got me into the supplements. You know what I mean? So I started the supplement line. Then I started realizing I was helping my wives because they thought it was just them. And then when I fixed them, their husbands realized they had
were looking at you like, wait a minute.
What you doing? So then I started treating the husbands because I was trained for both when I went to that, training with BioT. So I started treating men and women. And then I started noticing that, okay, yeah, I got my pellet and I was back on top of the world. I was losing my weight again. I was feeling great, helping all these people. But then I noticed that even as you age, and I was more like 45, that there was, even though I was doing the pellets and keeping my weight off, I was noticing changes just in my sexual function. Like things didn't work the same. Things didn't lubricate the same. Even with the testosterone, I still had to work really hard to have an orgasm. And I prefer having multiple orgasms. You know what I mean? Nobody's ever said they have too many orgasms or too frequent orgasms. So anyway, so I was like, we got to do something. So that's when I started diving into the vaginal tissue and the vaginal health and doing the O shots and the vaginal rejuvenation. And then when I fixed it for the women, the men, they're like, hey, you got my wife. Like, can you help a brother out? So that's when I started doing both. So that's how I started like taking care of men and women for sexual function, for total wellness, and for weight management.
Look, you out here changing the world.
Changing marriages, girl, because my ministry is marriage.
Yes.
So I love Black marriage. I believe in it. I know it's hard work, but this intimacy component is huge for marriage. And, just for me to normalize talking about sexual function, talking about the aging process and how when we age, our bodies change. Women get more vaginal dryness. Men have erectile dissatisfaction. But all of that can be fixed now.
Right.
Like we can have great, amazing sex until the day we die. If we do all the things.
And I'm glad you said that because some people feel like, oh, things have to stop working or it should be almost non-existent as you get older. And you've proven, and you're not old by any means.
Yeah, but I am
sure
maturing. And I plan on having great sex until the day I die. Like for real, I want to like wake up after an orgasm in heaven like, oh God, that was a good life. You know what I'm saying? Like, we're not doing separate beds and separate bedrooms. And my husband's gonna be doing the same thing. So everything I do for me, I do for him. And I've been able to do for my patients. So it is life changing. I get to take care of all kinds of patients. All different races, all socioeconomic statuses. But the one thing that I'm very proud of is that I'm bringing this to our community. Because these are things that we as Black people didn't know were important. We didn't know about the importance of intimacy or that you can balance your hormones or the importance of living a life of wellness so you can maintain your weight. This is new to us, but to be able to bring it to us and the rest of the community, that is like one of the most rewarding things.
Right. And that just goes to show that ministry can come in all different forms.
And y'all need some good intimacy for everlasting marriages. Okay? It may change up the way we do it, but you still need that true physical intimacy as well as all the other intimacies.
Right. Well, thank you so much.
My pleasure. Thank you for having me.
So you mentioned testosterone in women.
Okay.
Will you briefly talk about testosterone and how that plays a role with our women?
Okay, great. So everybody thinks about estrogen and progesterone when you think about female hormones, but I call testosterone the forgotten female hormone and the anti-aging hormone. Feeling like you're aging, so you stop sleeping through the night, you start having the night sweats, the low energy, the mood changes, the low libido, the decrease in orgasms, the mind fog, the joint pain, the belly fat, the mood changes. So even if you already have like controlled bipolar disorder or depression, anxiety, it worsens, or you can start having more irritability, like stuff just get on your nerves because it get on your nerves. Right. And then the weight management part, that's when women start to really gain weight and we start to notice more hair and acne and thinning of the hair when testosterone is low. So by replacing it with the plant-based bioidentical testosterone hormone pellet therapy is my favorite, but it can also come in a cream form.
Okay.
That's when you can get rid of all those symptoms, decrease your risk of heart disease, decrease your risk of osteoporosis and immobility from fractures, decrease your risk of dementia, and this is the most important thing.
Let's hear it.
It decreases the risk of breast cancer and the recurrence risk of breast cancer.
That's
so
super
the only
huge.
hormone that women can take after a history of breast cancer is testosterone. And we can put anastrozole in it to prevent it from going to estrogen and actually decrease the recurrence risk of breast cancer. So testosterone is one of the most important hormones. Women have about 1/10 of what men have.
Just at baseline.
At baseline, but women still need that amount that they had. We need it to age well, to live well, and of course to experience that everlasting intimacy.
So, what is one piece of advice you want to leave with our audience when it comes to building a healthy legacy from a women's health perspective?
That's a good question. You didn't give me that one before. So I think that just understanding the importance, especially for women, of putting yourself first and understanding that you can't take care of everybody else without taking care of yourself first, and that you're worth the investment in your health. And putting yourself first so that you can take good care of yourself. Because a lot of times with our women, we feel like our goal and our purpose on the earth is to take care of everybody else and neglect ourselves so that we can do that. But no, that's not how it's supposed to be. We're supposed to love ourselves, treat our bodies as temples, and do the things that we need to do to live a life of wellness so that we can give the people we love everything that we have. And you can't do that without your health. Like, your health is truly a huge component of your wealth. Without it, you can't have it.
Well, we appreciate you for coming on the show today. You have given us a wealth of information. So if people want to learn more about your services, how can they get in touch and or make an appointment?
So just Google Dr. Mia at MiBella Wellness Center. You can go to Facebook, MiBella Health and Wellness, and I'm Mia Cowan, MD on Facebook, as well as Dr. Mia Cowan, MD on Instagram. So just Google me, you'll find me.
Thank you very much. This has been another episode of Voices for a Healthy Legacy. Again, I am your host, Dr. Andrea, a board-certified family medicine physician. We'll see you at the next episode.